Yes, thank you, everybody. I would like to thank organizing committee and Dr. Ahmed Afghani, especially for inviting me for this talk. Thank you everybody to stay late in the night and the weekend. Today my talk about principle and long-term outcome of treat to target strategy. You heard a lot of this strategy recently, so I will just discuss the concept beyond treat to target, define treat to target, highlighting on calm study, and what we mean by tight control and long-term benefit of treat to target. Everything starts from this slide. This slide, you will find it in every presentation in IBD conference, because this is very important, highlighting the natural history of the disease. This natural history of disease, not like before, as we know, this area relapsing and remitting. No, it is a progressive disease. Progressive, and with the time, there is a bowel damage. And time means bowel damage. Each flare associated with damage, and this damage usually irreversible. This very important paper about Lehman Index, this is the first score to check the cumulative bowel damage over the time in relation to disease extent, severity, phenotype, and duration. And from Lehman Index, we can appreciate, which is a cumulative bowel damage score, we can appreciate from this study that when they look at in relation to disease duration, they found that the mean of Lehman Index are significantly associated with disease duration. So lower Lehman Index in patient who has disease duration less than 2 years, it was a mean of 6 compared to almost 20 in patient beyond 10 years. This will move us to important concept, which is we have a windows of opportunity. So it is a progressive disease with bowel damage, which is irreversible. However, we have window opportunities in the first 2 years or early in disease. If we optimize the treatment, that might at the end alter the natural history of the disease. Treatment goals, I think we have plenty of treatment goals. However, now moving towards the treatment goal to prevent the bowel damage. If you look to the guideline about the treatment goal, since over time, you find that becoming more strict now. From 2010 or beyond, before that, we are treating for symptom. It is symptom-driven treating strategy. However, recently we are coming to what you call the STRIDE. STRIDE, most of us familiar with the STRIDE. This is an international collaboration of the expert team. They put a selecting target for our therapy, and the most important thing, which is target, they put the target which is absence of ulceration. So absence of ulcer was the target in a STRIDE recommendation, and it has to be timely assessed. This is very important to issue in STRIDE. Treating two, which is a vital target, is mucosal healing and in timely. Why mucosal healing in STRIDE? At that time, it was based on indirect evidence. In terms of cohort, retrospective, and we found that mucosal healing was associated with better outcome at 1 year, and also has been shown in meta-analysis associated with better long outcome. Why untimely fashion? This based on also REACT study, which is the first principle of algorithm of treat to target based on algorithm. REACT was naive patient. They give steroid. Once they got they evaluate based on HPI. If the patient in remission, they taper steroid. If not remission, adding adalimumab with immune modulator, and then they assess in timely fashion, 12 weeks, every 12 weeks, taper steroid and reassess. And then randomize either continuous combination or coming every 3 months to check the HPI. Anyone above 7 HPI, they escalate, either escalating adalimumab dose, make it weekly, or switching anti-metabolites, or switching the anti-TNF. We can find from REACT that time to hospitalization and time to surgery was better in early combination immunosuppressive compared to conventional management, and this also was found in serious complication time to surgery. However, primary outcome was almost equivalent. However, secondary outcome was better in terms of hospitalization. After knowing this principle, now we are moving actually to have change in the course of the disease, to alter the natural history. The first slide I showed, now we are moving to what we call IBD care, which is based on 3 pillars and with the foundation of patient communication. So it's very important to have patient engagement, patient communicating with early intervention, if possible, within the first 18 months or first 2 years, tight control and treat to target. Treat to target concept, I think it was the rheumatology and our endocrinologists, they are ahead of us in treating their chronic disease, diabetes and rheumatoid arthritis, to the treat to target concept. Now, Crohn's disease or IBD is progressive disease and chronic. So we are adopting the same concept based on their experience. So the most important, what do you think the most important initial step in treat to target? Assessment. We said we are moving towards personalized therapy. Very important initially, the initial assessment of the patient. Stratify your patient. And then according to the risk stratification, you treat. If you don't reach the target, you need to intensify or switch or whatever. However, if you are in the right track, you need to keep tightly controlling it to avoid the long-term and alter the natural history. And we could, by the way, de-escalate, which is most of our patients coming and caused, as Dr. Faisal mentioned, that we could de-escalate and decrease the burden. So the initial assessment is stratifying your patient. You need to identify those patients with high risk, because those patients, we need to be really early intervening with them, intensify their therapy, and this is most of us, we know about this risk factor of disabling. So keep in mind those patients, younger, extensive disease, ileocolonic, patients with deep ulcer, penetrating, requiring steroid initially. Whatever you give, top down, step up approach, I don't care as long as we are using this strategy. High risk, early treatment, treat to target, intensify, and the most important, that intensifying or switching or intensifying your therapy, it should not be a symptom driven. CALM study was the first study to adjust the therapy, not symptom driven as most of us used to do earlier. It is based on objective monitoring. So monitoring based on some more objective than symptom only. So the CALM was the design, it is an open label, multi-center randomized trial, naive patient who have initial steroid, and then after tapering steroid, they randomized to clinical management. They intensify based on the CDI, only symptom-driven with the steroid use, versus the tight control arm, which is even the patient is he has no symptom. However, it has one of this, which is a fecal calc protector, more objective measure like fecal calc protector, CRP, steroid use. They intensify the therapy even if he is asymptomatic. I think 460 patients. We end with like 93 in 90 in each arm after some drop of some of the patient. If you look to those patients, their disease duration is median 0.8 years, so within the first year. So this is the area of windows of opportunity. And the most important thing in basic characteristic of the patient that fecal calprotectin more than 250 in 80, more than 80% of the patient in both arms, and also high CRP. So they are active disease. This is a primary outcome, which is at 48 weeks, which is based on more treating to target, which is CDI, not only clinical improvement. It is based on no deep ulceration and CDI less than 4. We can obviously see that tight control arm was superior than clinical management at week 48, which is a primary endpoint. However, multiple secondary endpoint was also positive. Most important to just focus on deep remission. Deep remission in secondary endpoint, which is CDI symptom is low, no prednisolone, so no steroid, and CDIS less than 4 with no deep ulceration. All this deep remission was also superior in the tight control arm. However, biologic remission, mucosal healing was also higher. The only thing that's complete endoscopic and in mucosal healing in all segment was not significantly difference. How about steroid-free remission? Was also better in tight control arm. Fecal calprotectin and CRB is a good tool and can correlate with the endoscopic outcome. The most important, because back to the economy, back to burden, back to cost, how about the effect on hospitalization? You can see that significantly fewer events of hospitalization, which is 29 events in symptom-driven or clinical management arm, compared to only 14 events in tight control. So the CD-related hospitalization was lower in tight control arm. Time to flare was also higher. IBD burden has a lot of impact on quality of life, so severe disease, active disease associated with impairment of quality of life. So also common studies showed that quality of life remission and response was better in tight control arm. How about economy? Because in tight control arm we escalate the dose and we add, we keep it weekly, then we add another antimetabolites. So definitely in tight control arm the adalimumab dose was higher, 30 compared to 24, and the cost was higher. However, this is the total cost of adalimumab. However, in CD-related hospitalization was higher in clinical management. So not only that, also the dose is higher. However, there was the dose optimization and treating, going to our target, some of the patient was able to de-escalate. Back to STRIDE, because I mentioned treat to target is absence of ulceration. This is the target. However, the terminology of tight control means monitoring. So you identify your patient, you intensify your medication early, you reach your target, but don't leave them. This is a message. You need to monitor them. And the monitor, it has to be based on a timely manner. This is what you call tight control, is a monitor. If you have active disease, risk certification, 3 months medication, then assess with more objective like CRP, calprotectin, and 6 to 9 months by ileocolonoscopy to reach your target. If not, you need to either intensify or switch. Can we do the best thing to monitor them is through colonoscopy. However, it's very difficult, it's costly, and we cannot offer every 6 months or 9 months colonoscopy. However, definitely medical adjustment of the medical therapy better in patient who's going for colonoscopy, even with no symptoms. So if you scope patient, even they are asymptomatic majority, we could intensify their therapy based on the endoscopic finding, even without without symptom. Biomarker is a surrogate marker for colonoscopy, and you can use it frequently. From Lehman Index study, we can see that elevated CRP associated with 7-fold increase in Lehman Index, so it could be used in relation to and can correlate to intestinal damage. Fecal calprotectin, also the same. Dr. Musa will give a biomarker tomorrow, a detailed lecture. However, even in POCR, which is post-operative Rutger score, fecal calprotectin also associated with endoscopic finding. CALM also, from the CALM we can also conclude that patient biomarker can correlate very well with endoscopic outcome. So if CRB less than 5 and fecal calprotectin less than 250, it correlates very well with the endoscopic outcome. And if you use both marker, has been also associated with and correlate very well with no deep ulcer and CTIS less than 4 if we use 2 marker rather than 1, and can guide your treatment, even optimization and algorithm. So can we trust biomarker in monitoring, in time controlling or monitoring? Yes, we could trust. Yes, we can. Biomarker are the main drive of treatment decision, the main tools for monitoring. It reflects endoscopic outcome and independent about disease location, because we use to mention is less effective than ileal. However, recent evidence showed that it can correlate even to ileal disease. So monitoring tool, symptom, biomarker is important. Endoscopy is the best. However, we need to keep in mind the cross-sectional image like MRI, CT scan, and coming up is the bowel ultrasound, which I think it might be a target and can be a monitor tool in decision making for the treatment of Crohn's. I will end with this schematic pathway. This is an illustration that about the factor that play a role in treating the target strategy. It was published by Prof. Columbel this month in journal Crohn's and Colitis. It is systemic review about treat to target, and they review all the evidence and they put this schematic factor. So the most important to setting your targeting, first of all, assess prognosis, stratifying your patient. Patient engagement, very important. The patient is the foundation of all the treatment, and the engagement we can use even some tools like telemedicine, IBD coach, website, whatever. So stratifying, engage your patient. It is a multidisciplinary approach. You need to target a consultation which is mucosal healing. You need to keep tight controlling through a good monitor, adherent therapeutic drug monitor. Actually, in this systematic review, the Prof. Columbel team and the discussion in the paper that also we have two prospective study about TDM, which is negative, tax and tolerance. However, there is a growing evidence can be TDM in induction. It can be a cost-effective, and then you reach your outcome, which is mucosal healing, clinical quality of life, very important, hospitalization, less surgery, health resources, which is economy burden and productivity. And this all through the treatment modification and keeping tight control with monitor. So just to conclude, treating only symptom is not a great target and not be target in 2020. Time to treatment, very important. So this early windows of opportunity we need to predict, especially in high risk patient. Time bound algorithm, which is in treat to target with style control is associated with decreased surgery, hospitalization, and complication, and we have to monitor beyond symptom. We have to have more objective measures, tools like CRP, calprotectin, to keep monitoring our patient. So stay calm and treat to target to reach our destination. Thank you.